Okay, so this 69-year-old female is presenting with distorted and blurry vision in the right. It's gotten better since onset. No complaints in the left. Past medical history of hypertension, possible white coat, borderline diabetes, hypercholesterolemia, systemic arthritis, ocular migraine, breast cancer, and Lyme disease. Surgical history of bilateral lumpectomy and cholecystectomy. Medications include lisinopril, pravastatin, and vitamin D. And VA on presentation was 2040 in the right, 2032 -1 in the left. IOP was unable to be obtained. So this is the first image.
So this is from cut and sort of the right eye. Media appears to be clear. Nerve appears to pink shot spot. Vessels look of normal caliber. My attention is drawn to the center of the macula where there is it looks like there's a hemorrhage centrally with a kind of radius outwards, and then maybe some few dots of exudates around and some mild thickening as well.
Yep. This is the other eye.
Color transfer of the left eye, media appears to be clear. The nerve appears to be flat. The vessels appear to be of normal caliber. They don't really look tortuous. And then in the macula, my attention is drawn to just super temporal to the fovea where there is like a dot plot. So the fovea looks similar.
Yeah, I agree with that.
So could you go back to the color photo, that one there? So what do you see about the red? Tell me about the red. Is it one color red?
No, it's darker in the center, and it kind of goes along the vessel. And then it's kind of a dimmer red around it.
So in general terms, what makes red darker or lighter red when you're talking about red in retinal photographs?
Yeah, so if it's intraretinal, it would be darker. So deeper hemorrhage.
So that you're on the right track. There are 3 spaces that hemorrhage can be in that you can see, but it's 4 spaces. So let's go from, if you think of the retina as a stack of pancakes, think of the very outermost layer below the pancakes. You can bleed into what space there?
Like the subretinal space.
Subretinal space. Even below that though, how about below the plate? What's that called?
Like at the front, level front.
Someone help her.
Arterial.
Sub-RPE,
Oh,
right?
okay.
Sub-RPE hemorrhage is one space. That's below the plate. Below the pancakes is subretinal hemorrhage. What if you get bleeding between the pancakes? What's that? Intraretinal hemorrhage. And then you get bleeding in front of the pancakes. What's that? Vitreous hemorrhage. Those are the 4 places that you can bleed. And depending on where the blood is, you may get different colors. What do you think would make the darkest red, the deepest red, or what makes red generally darker?
That's pre-retinal when it's closer to you.
Actually, I think it's darkest when it's under the RPE. It's
True, but that's not.
That's not the RPE.
That's
We don't have an
that's
example of
just
that.
thick. That's just,
Thick subretinal.
that's just thicker.
We don't have under the RPE here, but in general, the principle is that you get the darkest blood when the dark RPE is covering. And then you get similarly red blood when it's under the retina or infraretinal, but in different patterns. And then you get probably, depending on the severity of it, the least red blood when it's diffuse in the vitreous. But it's interesting that you have different colors of red there.
The thickness is a lot.
Yeah, but that's what we're getting. We're beginning to get into the weeds a little bit.
And for the vessels, the
Yeah.
vessels are always your biggest, tell you what's going on, right? Because if you can see, if you can see the vessel over it, then you're below intraretinal hemorrhage.
And then I'm looking at this, I also see this area of maybe like a grayish green, closer to the center of the macula. I don't know what that is. I guess we'll see on.
You point to it?
Yeah, I see what she's talking
Yeah.
about. Yeah, just on the top.
Okay,
edge.
good. Yeah, it's good to see that. There's a difference in color there,
She
yeah.
means here.
Yeah, right above the dark.
They can't see our pointer. You mean here?
I think she means,
Only the inferior.
Lower, yeah.
Oh, yeah, that's just different colors.
that's more of the red.
This is kind of fun because it's on the
Yeah.
edge. but-
We're getting a reflection off the light.
Oh, we can kill that.
Okay. So we can go on now. That's just because this is looking at the different colors of red. That's a really nice photo too.
Yeah, the high res.
Yeah.
Okay, so this is, I think, an IR.
Yes.
And in the right eye, it looks like there is an area of hyperreflectivity kind of surrounding this hyporeflective region within the center of the macula. And almost looks like there's some punctate hyperreflective spots there as well.
Okay.
And then in the left eye, it looks more hyper reflective, mostly still within the center of the macula, but in a patchy distribution. And we're kind of missing the hypo-reflectiveness of the foveolated vascular zone that I would expect.
And
You know, the IRs don't show that.
and in the right eye, you can really see what Dr. Singer was referencing. Look at that vessel. Is that an artery or a vein associated with the lesion that corresponds to the red lesion?
Artery,
Right? Is it over the red? What is it over the black spot or under the black spot?
over the forehead.
Clearly over the black spot. That helps you tell what layer the blood is in. If it's under the vessel, it's in the subretinal or deep interretinal space or in the sub-RPE space. But like Dr. Pavin said, we don't have an RPE pathology going on.
So instead of just focusing on that one lesion, also kind of look around at other areas. And it will give you a clue as to what's going on, because there's an underlying systemic risk factor, which is showing up also in the other eye.
Mhm. So there's also, I'm looking at the vessels here. Maybe from here looks like some slight venous bleeding. I'm not seeing, it's hard to tell from here, but it's like bleeding like.
You mean this stuff, right? These vessels are all a little scraggly. All right, you can go ahead.
There's a fluid line there
Yeah.
you didn't talk about. It's here too,
Sorry, Dr. G.
in the temporal macula, go back.
Oh,
There's a line there,
Yeah.
see it, in the temporal macula on the right eye?
this-
Go down. There, yeah, there's
Yeah.
some line.
IRs are funny though.
Well, it's still, all right, go ahead. Go to the next one, go to the
Yeah.
next
So
image.
that could be residual.
Okay, so this is a finished autofluorescence image of the right eye. And it looks like there is an area of hypofluorescence along the vessel inferiorly, still involving the center of the macula with a ring of hyperautofluorescence around it. And that ring looks like patchy hyper and hypoautofluorescence.
Okay, move to the next one. Doesn't tell you a lot in this case.
So this is an OCT image of the right eye, and I do see a foveal contour there, but it looks elevated. Appears to have in the above the RPE, so basically the subretinal space, there is hyper-reflective material deposits, whatever we can call it.
Subretinal hyperreflective material, SRAM. Is exactly right. You got it right.
But otherwise the layers look intact. There is some slight disruption of the outer retinal layers just adjacent, but maybe parafoveally, nasally. But otherwise, and then there's small hyper-reflective punctate spots scattered within the layers that are probably representative of exudates. And then I see the posterior hyaloid in there.
Okay. Next slide.
It's like there might be some stuff in the tree.
Yeah.
Yeah, this is a
Central.
different cut. Do you know which way this cut's going?
This is probably vertical.
So the left side is the inferior superior part. Left side of the image.
The left side is maybe.
Left side's inferior. It's important for the orientation. I didn't expect you to know. If you go back one slide. You can tell that this is a horizontal cut, and it always cuts left to right with the Heidelberg, and you can tell that it's horizontal because you have thickening on the right side of the inner retina corresponding to the nerve fiber layer. And then if you go to the next slide, this is the second part of the crosshairs, and always cuts bottom to top. It always slices bottom to top in the Heidelberg. So it always cuts left to right, which is temporal to nasal in the right eye and nasal to temporal in the left eye, but it always cuts bottom to top. And this, that's no our scanning protocol. We typically do crosshairs and then a raster map. So this is left side inferior, right side superior, cutting through the center of the macula. What do you see?
So here I'm seeing, maybe closer to the inferior side of the retina, there's, a large hyperreflective, area that encompasses the inner retinal layers, kind of casting a shadow behind it. And, so we're unable to see the outer retinal layers in that region, kind of descriptive of a hemorrhage. And then, can still see that elevation, above the RPE there, subfoveally with the deposit, hyperreflective deposit.
Yeah, good, excellent. Next. Left eye, normal or abnormal, more or less?
More or less.
Normal, good. Next slide. What do you think? More or less normal or abnormal?
Still more or less normal.
Good, next slide. We'll belabor the normals. Okay,
Okay, so
this is
the-
beautiful. Where do you see? This is really cool. Think about Dr. Singer's comment. And this is not really early. It's very hard to get really early pictures. This is already in the AV phase. This is our earliest image, I assume, on this case. It's hard to get, because you do the stick and the patient's leaning back and they're stressed out because they're getting injected. Then they have to come into the camera, then they have to put their
Then it's
chin
bright.
down, then it's bright, then you have to focus, and then it's 20 seconds into the study, and then you're regretfully done with your arterial and your laminar phase here. You're in what I call transit in my training, what other people call peak, which is AV. So you're probably 25 seconds into the study here, or something like that. Yeah. What do you see though, considering that you're 20, this is our earliest picture?
So I'm seeing, this area of hypofluorescence in the center of the macula with the vessels, kind of fading out into, hyperfluorescent areas that don't have discrete margins or borders.
In the large, is a large retinal vessel visible over the hypofluorescent lesion?
Yes.
Yes, good. And the rest of what you said is generally accurate. Do you see, what do you characterize those little abnormal bright spots as?
Staining.
Well,
Or actually, I don't know yet.
I don't know yet,
Yeah.
but they're, what lesions do you think they are?
The exudates.
Exudates don't get bright. They have to have flow to get bright.
Okay, yeah, MA.
Amazing, yeah, microaneurysm. Good, okay, let's see what happens.
About the same in the next slide here. And then-
A little bit, we're gonna do a nice clear one, maybe 30 seconds later. Next one. One more. That's not available yet.
I think that was the last one.
Yeah, go back. Okay, this is good. So what do you see?
Yeah, so this is like a lake image, and there's, I would say, leakage there in the center of the macula from those vessels with the hyperfluorescence, that is kind of used around the borders.
And you see what Dr. Pavin was talking about too. Do you see the swath of hypofluorescence kind of going from the right to the left downwards like a waterfall?
Almost looks like that.
Yeah,
Yes.
exactly. Patient probably sleeps on their right side.
Yeah, when I saw this, I was thinking more it was like between leakage and pooling, but with just these two, it kind of just filled up the same spot. So I wasn't sure if it was
Do you think they're leaking? Do you think they're leaking or pooling?
I think they're pooling.
Our fault. We have to bring you some good examples of pooling. This is leaking.
It's tricky.
It's
So
tricky,
so
yeah.
pooling is leaking into a space with
Like
fluid.
think about filling a hot tub. You guys are young. You guys hang out in hot tubs every weekend. Think about filling. Think about filling a hot tub. That's
They
cooling.
can't to me, but no.
Yeah. So think about think of it, when I was a resident, I hung out in hot tubs a lot and I never got a cantilever, but it's a risk factor.
Exception that
So-
proves the rule.
So if you think about pooling, you think about a hot tub upside down as like a pigment
It's
epithelial.
a sewer, that's what a hot
It's-
tub
it
is.
is- you're
Fancy sewer.
absolutely right, absolutely disgusting, but cooling is like filling a hot tub. Leakage is like spilling a cup of coffee onto the sidewalk more, so it's hard to come up with a good analogy for leakage. but
It's
leakage-
because the terms aren't relevant.
Yeah,
Because this is leaking into tissue because we know
Yeah.
the disease.
yeah,
I
yeah,
mean, we've all decided, all the attendings know what's going on.
Yeah.
Okay, maybe some of you guys do too, but we've decided, knowing that, we're
Yeah.
gonna call it leakage.
leakage, yeah.
And we're not
There's
gonna
truth-
call it
there's-
cooling
there's
because we
truth
know
to
that
that,
disease.
yeah.
But if we didn't know that, we would call, it could be either.
Yeah,
Right.
it could be either,
So it's.
yeah, it's tough,
it's-
but we have to bring you, we can bring you some really good examples. of cooling.
Well, you
Mental
can't,
stereotypes.
the reason
Yeah.
it's not particularly valuable now is we have OCT.
Yeah.
When these terms were popularized, we were trying to struggle with all this stuff on fluorescein, and we really didn't know what was going on. I mean,
Mhm.
now we just with the imaging, it's just wonderful.
Like a backup camera, it's cheating,
Right.
yeah.
Yeah,
It's
the
in my
reason,
car.
the reason I brought this up was the slide, to me, it looked like leakage originally, but the slides that I was given said it was not leaking. Specifically.
Oh, sorry, that was one specific part of the lesion's not leaking. So parts of them are leaked, yeah, that's my fault. So there's one aspect of it, but go ahead.
We can go on to the next slide, here's the left eye. Oh, we took listeners, and we did
They transit on the left eye, this may have been a miscommunication, it probably was.
This is a really nice early phase photo. This is
Right, you were king of the world, none of this would happen. You just put people to death.
Yeah.
You know,
What?
This was Rome.
This is- But if we did that now, we wouldn't be able to hire someone for like months to.
No, the thing is, it's Rome and hire people.
It's like, yes,
I'll find another
blame them.
It's
Yeah, our practice is a fantastic place of work.
You could reward them for good FAs.
Yeah.
Demerit
Yeah.
their salary for that.
So this is the left eye. Go ahead with the left eye.
Left eye, late now. And it looks like there's patchy height.
There's a teaching moment there. Go back one slide and go forward one slide. How much time is between those slides, do you think? How long does it take to go in a healthy eye, relatively healthy eye, from arterial phase to AV phase?
I would say a few minutes.
It takes, so Dr. Pavin taught me I only have to count to 4 as a retina specialist. I've doubled my intelligence since I now do belt loops in my buckles. I now count to 8, and that's a big number for me as a retina specialist. I have to count to 8. But Dr. Pavin told me I only have to count to 4. And it's one of the things you count to 4 at. It's 1 second from choroidal flush to arterial fill, 1 more second from arterial fill to some venous fill. So it's 1 second between those pictures in a healthy eye.
So your previous image was arterial.
And this is now laminar venous or
You
AV.
don't get that.
Yeah.
It could be it could be.
Could be a few seconds,
But
but
it's just seconds.
it's quick. Yeah,
It's very fast.
probably more than 1 second between those pictures, but probably not more than 5. Anyway, so you see that it went from, go back one more time just so we can show what we're talking about. That's arterial phase, and the next picture is less than 5 seconds later, laminar venous phase.
And
Okay.
it's laminar first where it's nearest the disc. And as you go out, looking at your temporal quadrant, there's almost no laminar in that part of the vein.
I'm gonna ask you to go a little bit quicker.
Okay, yep, go ahead, yep. All right, what do you see?
So in the previous slide, there were 2 areas of hypofluorescence. Now I'm seeing that one of those areas has this overlying area of hyperfluorescence. Still have that arc of hypofluorescence in the center of the macula, and then just kind of maybe some patchy hypoautofluorescence temporally as well.
Okay, next one. One more. That's all we, okay, go back. All right. Do you see anything dramatically different here than the previous picture?
Yeah, can you go back, call it one more time? And then again.
They go forward, forward one more. Okay, good. Leaking or staining,
It looks like staining actually.
or leaking a lot
Maybe.
less. Yeah,
Yeah.
not a lot going on, but there's, yeah.
Maybe
Because of all the biases Dr. Pavan mentioned, I'm calling it slightly leaking, but
Maybe
yeah.
some cooling, since it looks like it's not that.
could be, but it's getting a little brighter, it's getting a little fuzzier between this picture and the picture, 2 pictures back, but not a lot. It's not profound. I agree with you that it's not profound. Okay, next slide.
Yeah, just
Give us
the
a different.
findings.
Go ahead.
Um, do you want to say them?
Yeah, I remember some. So there was hyperreflective material about the RPE in the right eye. There was a hemorrhage present as well. And then some hypofluorescence, I think, was in the right eye. And possibly some that guttering look. My memory is failing me right now.
Yeah, basically, like the patient came in again with the reduced vision in the right. There's some bleeding, pooling, possible leakage, parafoveally, and lipid exudates in the right eye, and then left eye there was that little area of leakage as well. And then for differential,
So considering this patient's history of diabetes, I would see diabetic retinopathy, possibly hypertensive as well, but I don't think so. Could be a RAM, could be any of the differential for like an occult CNV as well that we wouldn't have been able to see. Another thing I was surprised we didn't get was maybe an ICG to look for like a polypoidal.
Oh, for neovascular, yeah, I didn't think that was an up for me.
One more big thing on the differential, you can always throw in with diabetes and hypertensive retinopathy. No, MD's different differential.
Radiation retinopathy.
You can do that, that's good. You can always put that with diabetes. One more common than radiation, RVO, vein occlusion. You can always say diabetes, hypertensive retinopathy, radiation retinopathy, vein occlusion, and you said RAM too. And you could all, because it has some of this subretinal leakage, you can go down the choroidal diseases thing like CNV, PCV. It can be a broad differential for this one, but you were going down the right track, I think, with mostly retinal vascular disease ahead of choroidal neovascular diseases.
yeah, that's basically the same, pretty much same differentials I got, and especially with the RAM and the PCV, and it turned out to be RAM.
Venous macroaneurysms.
You can, actually, I was
Yeah.
glad you put that
Yeah.
up there, you get them on
Can
the
you?
collaterals for
Really?
RVOs.
I've never
Yeah,
died.
They respond beautifully to laser. I have a case in my stack. I'll bring it up for
Okay.
conference. Because if you ever get an RVO where 3 to 4 years later, they start to get edema, you put one laser spot on the venous macroaneurysms.
Yeah, so interesting. I've not seen that.
Get a
but that's
collateral
cool.
scan.
Yeah.
So if you go back to the fluorescein in the right eye, you can kind of get a clue. So it's hard to get FAs on these on RAMs, but you can see how it kind of lights up off the artery.
Yeah, it's always,
So a lot of
yeah,
times
I was
it's gonna
hoping,
be blocked by
Yeah,
blood.
yeah,
But when
yeah.
you see that, that's kind of your clue.
I was disappointed when it didn't light up more, but yeah. it
Well,
does
it-
block
Well,
that.
but that's
You're
one of
lucky
the
to
things
see
for the
that,
space.
actually.
So
Yeah.
the other thing, funny, I've been around so long, I don't even know what RAM is until I realized it's
Right.
already macroaneurysm.
Me too.
But that being said, when I learned about macroaneurysms, it's one of the things where you have blood in multiple layers of the retina. There are very few things that give you blood, and you could put a little vitreous hemorrhage on top of that to his pancake analogy.
Mhm.
That's where you're essentially, when you start, you're looking at a lot of different layers, and you now have multimodal imaging to do that. That should really be the thing that really kind of trips you off.
Right,
even
so
without this.
Saying, yeah, the OCT, you can tell,
Yeah.
you can't really see any vitreous hemorrhage on those pictures, but if you look at the OCT, you can see that
Yeah,
hyperreflective.
Yeah,
but we thought were cells, right?
Yeah, a little bit of, maybe a little bit of vitreous stuff, definitely intraretinal, definitely subretinal. Doesn't go sub-RPE, as Dr. Pavan pointed out at the very beginning of this case. Now what's interesting is the other eye has a little residual RAM in it too.
Yeah.
That's the funny thing
The
about
patient's
this patient.
diabetic too, so some of this, I think some of this is just.
Oh, okay.
Really?
yes, I wondered how you did it.
That's nice.
And I bet that's an old small RAM, but
It might
anyway,
be
yeah,
hypertensive.
yeah, hypertensive.
Are the lipids and MAs that we saw part of the constellation of RAM as its own?
There you go. Say again?
Are the lipids and MAs part of the constellation of RAM as its own entity, or is that just from the patient's comorbidities of hypertension?
I think the MAs are unrelated to the RAM.
Yeah.
I was gonna go through the
Yeah.
difference a little bit.
Yeah,
later.
go ahead.
Okay, yeah, sorry, you start, let's let you.
You can't get any fluid absorbing to be excellent.
But yeah, anyway, this the patient had a follow-up, and this was what was noted on the slide. So it had already bled. There was no leakage on FA, which is what was given to me. Both signs of improvement, no treatment was done. Follow-up OCTs shows scans, vision improved to 2032. These are the follow-up OCTs showing improvement with just observation. So with the retinal artery macroaneurysm, it's an acquired ectasia of first three orders of the retinal arterioles, it can be insidious versus acute vision loss. It can also present with metamorphopsia. In the Beijing eye study, which is one of the only epidemiological studies, 1 in 9,000 people had it, majority were elderly female. And in the hemorrhagic form, which I'll go through the different forms in a couple slides here, 10% are bilateral. Pathology-wise, it's vessel wall infiltration with fibrin and foamy macrophages. So basically, arterial sclerotic changes leads to collagen remodeling, increased permeability of the vessels, and ultimately dilation, thinning, and weakening. And these ectatic vessels are prone to rupture and exudation. So the difference between a microaneurysm and a macroaneurysm, macroaneurysm is usually from the capillaries, usually up to 100 microns in diameter. Is due to basement membrane thickening, parasite loss, like in diabetic retinopathy and endothelial cell death, versus macroaneurysms more from the arterioles, up to 250 microns in diameter, with the vessel wall thickening, hyalinization, ultimately dilation, and associated with formation of artery-to-artery collaterals and telangiectasias, which can sometimes be complications that you can find on the FA and fundus exam. So for the risk factors, the most important one is chronic systemic hypertension. It's also associated with a lot of the other diseases that were, presented in the differential, Coast disease, von Hippel-Lindau with the hemangioblastomas, diabetic retinopathy, radiation, Irvin, and BRVO. To prevent it, you want to control that blood pressure and try to reduce arteriosclerotic risk factors such as cholesterol.
Coates disease was named for George Coates, so not George Coate. So you put the apostrophe after the S.
Oh, okay. Interesting. I didn't know that.
Get a little thing.
But there's three major forms for the macroaneurysms.
Good details are important. Go ahead, sorry.
There's three major forms for the macroaneurysm. Is quiescent form, usually peripheral, less than 1 disc diameter of hemorrhage if it's present. So that one you wouldn't really find that unless you're just looking randomly in the eye. Hemorrhagic, which is what I think this patient had, is basically usually acute with saccular dilations along either the first or second order arterioles. So it can be present in the macula, which in our patient's case it was. Multi-level hemorrhages, so preretinal, interretinal, and subretinal. And patient's case here, it looked like preretinal and subretinal to me. This one's more associated with hypertension and sometimes can be exacerbated with the use of anticoagulants and antiplatelets. Interestingly, from what I saw, there's not many disease processes that cause hemorrhage in all layers. The only ones that I found were like abusive head trauma and leukemia other than this one. Otherwise, the last of the forms is exudative. It's more of a gradual course with lipid deposition. Also has the worst prognosis due to chronic relapsing and remitting course and can cause permanent vision loss versus the hemorrhagic, which oftentimes does clear up. And the exudative is associated with RVOs. And also just a cool point, if you see spontaneous pulsation, it means that there's a pending rupture. So for diagnostics, excuse me?
I was just gonna ask a quick question, Dr. Cohen, if you saw like, or Dr. Martin, when you guys saw this pending rupture, spontaneous positions, would you go ahead and laser that?
I've never.
That's a tough one. Are you gonna do treatment at the end?
Yeah.
We can do, talk about.
Yeah, go
treatment.
ahead.
I've never seen one
Treatment's a-
spontaneous pulsating.
You can get a room call.
Yeah.
I thought it was during surgery.
Yeah,
I tried to evacuate a hemorrhage. That was.
yeah, I've never seen one in the clinic yet, spontaneously pulsating. Have you seen one?
No.
No, I don't know, that might have been like one case report or something.
Play with laser with this is.
Yeah.
For disaster.
Yeah,
All right, keep going. Good.
Yeah, so for diagnostics wise, you can use an FA. It's going to have rapid arterial phase filling, round ovoid pooling, followed by leakage from the aneurysmal parts. The exudative forms may block FA, and it may also show some telangiectasias. ICG, you're going to have a hyperfluorescent area, and it's useful, especially if there's a really thick vitreous hemorrhage obscuring your view. The OCT, again, these hyperreflective lesions in the inner retina, shadowing of the underlying structures. You could also see hemorrhage and lipids, and you could also use OCTA and B scan as needed. For complications, you can have persistent macular edema. Most of the time that's in the exudative form, thrombosis or occlusion, ERM, subretinal fibrosis, neovascularization, and serous or hemorrhagic RD. In terms of the treatments, obviously there's the observation. Usually most of them are self-resolving within 3 months or so. However, if there's no improvement or there's some vision-threatening complications that are starting, you can do a laser photocoagulation directly to the ruptured ram or indirectly around it. FA can be useful to kind of find these specific leaking points that you can laser. You could also use subthreshold laser, which I believe is kind of like micropulse. So it increases the heat shock proteins in the RPE, kind of gets them running a little bit more. In terms of if you have like a submacular hemorrhage, you could do a pneumatic displacement. And you could also, I was reading that some people are also using intravitreal TPA in addition to that to kind of break up the hemorrhage a little bit more and kind of squeegee it out of the mac a little bit. In terms of other therapies, anti-VEGF intravitreal injections have been used. You could also do a YAG hyalodotomy to disrupt the ILM and release, especially in the release of trapped hemorrhage that's just stubborn and not going away, kind of in the subhyaloid space, and then pars plana vitrectomy for non-clearing vitreous hemorrhage. And then in prognosis, as I said before, hemorrhagic's a little bit better than the exudative form. And that's basically it.
That's very nice. Thank you. That's excellent.
yeah. So treatment, let's talk, we can talk about treatment for a second. These ones that rupture, they, like this case shows, they often don't need treatment, but I think there are reports of them being treated with anti-VEGF,
Yeah.
not that they need it. Do you treat them?
I do treat them.
I've
'cause
treated
they-
them
They
before.
clear quicker.
Yeah.
I mean, so again, it's a
Especially if
function of
there's
time,
edema.
right? There's
Yeah.
edema, and again, it
Yeah.
contracts nicely and they work really well. And the bottom line is that one of the things for whenever we do these things, we don't throw in time as a factor. These people have real life. So if you can clear this blood quicker without taking them to the operating room, that's a nice process.
Yeah.
How often do you do the pneumatic displacement for the macroaneurysm? Is that every time?
So that's super preferential. I love pneumatic displacements for large submacular hemorrhages in wet macular degeneration. Not that they work all the time or even most of the time, but they work some of the time and they're very low risk.
Yeah.
And when they do work, they're beautiful. And I stopped taking patients to the OR for vitrectomy and pneumatic displacement and TPA a long time ago, but in the office, I like pneumatic displacement for but this was not enough blood for a pneumatic displacement.
Yeah, there's a sweet spot for pneumatic, I think most of us probably think. And so for pneumatic displacement, I think if it's 2 disc diameters, 4 disc areas, you're probably not gonna do it. If it's, out to the arcade, you're probably gonna do it. If it's way beyond the arcade, you're probably
Not
not
gonna do it, yeah. Like-
So there's this weird in-between spot.
And everyone does it a little differently. I do it with a C3F8 bubble in the office and I ask them to be face down for like 3 days and they can do that.
Have
what
you
do,
ever
Steve?
yagged a retina for one of these before?
I have not.
The TPA, that question is whether that could penetrate subretinal phase.
Mm.
The answer is probably doesn't, but you feel good about that.
Yeah, also, you know, when you have a large submacular hemorrhage, you have, it's a real Hail Mary, you know, the patient's gonna do pretty badly with it, with no intervention.
That scar's gonna be a disaster.
Disaster.
I usually used to use TPA, but to Peter's point,
Interventional or subretinal.
and I used to do intravitreal.
Yeah.
Now I just throw an anti-VEGF in and I get
Yeah.
pretty much the same thing.